Good morning. My name's Annie Keeler. I'm one of the emergency medicine, family medicine residents. The format of the EM rounds that are led by the EM residents is slightly different this year. The intent of this is to enrich our academic program by having more guest speakers throughout the year to enrich our understanding of a specific topic. So today, Dr. El-Sadi and I decided to look at death in the emergency department, and we've invited Dr. Rick Mann to come and discuss some cases with us and go through some pertinent points with us. So the objectives today are to appreciate the importance of an accurate death certificate and very briefly discuss how to complete a death certificate. We'll also discuss certain clinical scenarios that would require a coroner to attend and have a basic understanding of the coroner's roles and responsibilities. So the death certificate, as seen here, needs to be completed with a black or blue pen. You want to press hard so that you can make a couple copies with it. And the most important thing to look at is in part 1, where it says the underlying cause of death. This is the disease or the injury that has essentially initiated the train of events that led to the death. So that's basically the last part that goes in part 1. So why is a death certificate important? First of all, it's a legal document and it has many implications. It's required for the body to be released to the funeral home. It's important for end-of-life legal matters such as life insurance, inheritances, and to access and terminate any government services. Also, the epidemiology gained through the cause and manner of death informs health policy, research, and resource allocation. It also can help with closure and understanding for a family, and also allows a family to be aware of familial diseases. So just a quick show of hands, how many people have had proper training in death certificate completion at a medical school level? So very small number, and I think that actually goes along with what's been found in the research. So an American study found that 60 to 70% of physicians have never actually been trained in how to complete a death certificate. Recent graduates tend to have received more often formal education, but still education tends to be lacking. Interestingly, there was a study done out of Boston that had a group of emergency medicine residents and internal medicine residents go through a clinical vignette, a web-based vignette about a patient, and it basically was an accidental death with a lot of other factors involved. And they asked the residents up front, how many of you feel comfortable completing this death certificate? And the majority said they had a high level of confidence that they'd be able to complete it correctly. However, only 10% actually listed all the contributing factors, and only 35% of the residents actually listed the injury as a contributing cause of death. Physicians who had more experience tend to be a little bit better at completing death certificates more accurately. However, only half of death certificates are completed to a minimally acceptable standard, and interestingly, 10% of death certificates are actually found to be illogical or inappropriately completed. So another interesting question is, as physicians in the emergency department, how good are we at determining or guessing what a cause of death is compared to the actual cause of death? And it's probably not as good as we think. There's been some studies out of Germany, Belgium, and Australia that have shown some major discrepancies between what the emergency physician predicts as the cause of death and the actual cause of death as determined by autopsy. And those discrepancies have been found on the order between 15 and 75% of deaths in the emergency department. Thankfully, a lot of these deaths probably wouldn't have been altered, and the care wouldn't have been altered based on the determination of the cause of death. So how many at this time feel very confident in their decision to notify a coroner? Okay, so that's pretty good. So we're going to go through some cases. We're not going to discuss them necessarily right now, but if we can use them as a jumping off point for when Dr. Mann gives his talk, that would be great. So for the first case, we have a 5-year-old boy with a history of leukemia, and he's had many treatments, but unfortunately they've all failed. He's been unwell for the last 2 days, and his grandmother decides to drive him to the hospital. On the way to the hospital, becomes very lethargic, and so Grandma pulls over the car and calls the EMS. When they arrive, the patient does not have vital signs and CPR is started. Unfortunately, the child cannot be resuscitated. In our second case, we have a 75-year-old female. She falls at home, hits her head on the stairs. After an initial period of lucency, she becomes unresponsive. EMS is called. Her GCS is 5, and she's intubated in the emergency department. The CT scan shows intracranial hemorrhage, and neurosurgery says they're unable to offer any intervention. The family decides to extubate the patient, and the patient dies in the next few minutes. Third case, a 55-year-old man is found unresponsive at home. CPR is started by a family member and is continued by EMS on the way to the hospital. In the emergency department, the ultrasound shows no cardiac activity, and the patient, in the background history we find out, has just been discharged from the CCU following stent placement. The fourth case is an accident. It's a 25-year-old male belted passenger in a highway speed car accident. He's quite hypotensive on arrival to the emergency department. As you're getting the lines in, you lose his vital signs, but resuscitation is, ultimately fails. Case 6 is a 66-year-old woman who's been febrile and feeling unwell for many days. She's hypotensive when she arrives to the emergency department, and her resuscitation also fails. And finally, we have a 40-year-old male, history of IV drug use, and he's also an alcoholic. Everybody in the department knows about this patient. He's there almost daily because of intoxication. He's found unresponsive at the men's mission. CPR is started. On arrival to the emergency department, no cardiac activity is seen. Now, this is a slightly different case, and I just wonder what a coroner would think or say in this case. So we have a 5-month-old boy. He's found unresponsive and blue in the bed. The mother starts CPR, and it's continued. He arrives to UH. Resuscitative efforts are unsuccessful, and you've already called the coroner. The mother asks to hold the baby. How many people would say, sure, go ahead and hold the baby? Okay. And what if the mom tries to pull off some leads? Is that different than if the mom tries to pull out the IV? And what if she tells you, whatever anyone says, I'm going to refuse a postmortem examination? Okay. So now we're just going to have a coroner's perspective. I would like to invite Dr. Mann to come and talk with us.